Thank you for answering the pretest. Hi, I'm Dr. Orpheus Monakil, member of the Philippine Pediatric Society Southern Tagalog Chapter and a pediatric nephrologist. Welcome to Ihing Mapula, Kayang-Kayang Maapula, an online CPD on acute glomerulonephritis, recognition, outcome, and monitoring. The following are our learning objectives. 1. State the disorders affecting the glomerulus, particularly the glomerulopathies. 2. Understand the differences between nephrotic syndrome and nephritic syndrome or glomerulonephritis. 3. Discuss the pathophysiology and clinical manifestations of acute glomerulonephritis. 4. Describe the appropriate initial investigations in the diagnosis of glomerulonephritis. 5. Outline the plan of management in such patients. And 6. Recommend monitoring measures in the follow-up of children with acute glomerulonephritis. For the purpose of this module, let us define some terminologies. Nephritis. It is the inflammation of the kidney. Glomerulonephritis. It is the inflammation involving entirely the glomerulus. Interstitial or tubulointerstitial nephritis. This involves structures outside the glomerulus or the area between the nephrons, or what we call the renal interstitium. Nephrosis. It is the renal disease without any inflammatory component. Glomerulopathies are oftentimes easy to recognize, but management differs. Thus, it is very important for clinicians to differentiate one from the other. The following slides will help us understand the differences between the common glomerulopathies, particularly nephrotic syndrome and glomerulonephritis, which will be termed nephritic syndrome in this presentation. Focus your attention on the urinalysis of these patients. Nephrotic syndrome patients will usually present with foamy and frothy urine, which would usually signify massive proteinuria. On the other hand, patients with glomerulonephritis usually present with tea-colored, cola-colored, or smoky urine, which will represent RBC in the urine, which are usually dysmorphic upon urine microscopy. Note that in glomerulonephritis, the GFR may be normal or decreased at the time of the diagnosis as compared to patients with nephrotic syndrome who have often normal or near normal GFR. Also, serum C3 are usually normal in patients with nephrotic syndrome but may be normal or usually decrease in patients with glomerulonephritis. Prognosis are usually favorable in patients with nephrotic syndrome and good in glomerulonephritis patients. Representative pathologies for nephrotic syndrome are minimal change disease and focal segmental glomerulosclerosis, while on the other hand, the representative pathology in patients with glomerulonephritis is the prototype, which is termed as post-infectious or post-streptococcal glomerulonephritis. Glomerulonephritis is the most common non-suppurative disease of presumed immunologic origin affecting predominantly the glomerulus. It may be classified either based on duration or affectation. It could either be acute, persistent, and or chronic, or primary and secondary. Acute nephritis is the sudden appearance of edema, oliguria, hematuria, hypertension, or renal insufficiency in a child who had no previous renal disease. It could either be infectious or non-infectious in nature, 80 to 90% of which is due to streptococcal in etiology. Persistent glomerulonephritis, on the other hand, is significant glomerular hematuria and or proteinuria repeatedly or intermittently beyond 1 month of illness. In this condition, resolving PSAGN or relapsing idiopathic nephrotic syndrome should be excluded. While chronic glomerulonephritis is nephritic disease with lesions indicative of irreversible renal damage, persistent GN and chronic GN should not be used interchangeably since chronic GN has a poorer prognosis and outcome. Another way of classifying glomerulonephritis is based on the manner to which the glomerulus is affected. If the glomerulus is primarily and almost exclusively affected, it is termed as primary glomerulonephritis. While if it is part of a systemic pathology, it is classified as secondary glomerulonephritis. Let us now look at the etiology of primary glomerulonephritis. All organisms, such as bacteria, viruses, fungal, parasitic, can possibly cause glomerulonephritis, and as previously mentioned, majority is caused by Streptococcus or group A beta hemolytic strep, which is the prototype. Non-infectious causes of primary glomerulonephritis are usually isolated asymptomatic hematuria, IgA nephropathy, or membranoproliferative glomerulonephritis, while secondary glomerulonephritis can be caused by or due to systemic diseases such as collagenoses or even part of sepsis and some malignancies or even tuberculosis. Focus your attention now on acute glomerulonephritis, which is the main topic for this module. Acute glomerulonephritis refers to a variety of renal diseases characterized by sudden onset of edema, hypertension, hematuria, proteinuria, oligoanuria, or azotemia in a previously well child. PSAGN is the prototype of AGN, and it is a delayed, non-suppurative complication of pharyngeal or skin infection with certain nephrogenic 3 strains of Group A beta hemolytic streptococci. 3 strains of Group A beta hemolytic streptococci. 3 strains of Group B beta hemolytic streptococci. 3 strains of Group C beta hemolytic streptococci. 3 strains of Group D beta hemolytic streptococci. 3 strains of Group E beta hemolytic streptococci. 3 strains of Group F beta hemolytic streptococci. 3 strains of Group G beta hemolytic streptococci. 3 strains of Group H beta hemolytic streptococci. 3 strains of Group I beta hemolytic streptococci. 3 strains of Group I beta hemolytic streptococci. 3 strains of Group J beta hemolytic streptococci. 3 strains of Group K beta hemolytic streptococci. 3 strains of Group L beta hemolytic streptococci. 3 strains of Group M beta hemolytic streptococci. 3 strains of Group N There are several nephrogenic strains of group A beta hemolytic strep that can cause AGN, most common of which is serotype M12 for pharyngitis and serotype M49 for skin infection. Severity may vary from either asymptomatic to patients who develop complications such as acute renal failure. Let us now deal with the pathogenesis of the disease. The actual mechanism is not fully understood. But there are several factors that may indicate the immunologic mechanisms of AGN. 1. The presence of latency period between infection and the development of nephritis. 2. Hypocomplementemia during the acute stage and the presence of immunoglobulins, complement, and antigens that react with streptococcal antisera are detected in the involved glomeruli. There are also several mechanisms regarding the immunologic nature of the disease. The proposed mechanisms are the presence of circulating immune complex formation. 2. In situ immune complex formation. 3. Neuraminidase produced by streptococci alters endogenous immunoglobulin G and makes it autoantigenic. And 4. Autoantibodies are formed in the altered IgG, leading to the formation of circulating complexes which are then deposited in the kidney. Understanding the pathophysiology of acute glomerulonephritis is important in knowing the clinical manifestations of the disease. As mentioned, immune complexes are formed and deposited in the glomerulus. This is followed by glomerular infiltration by inflammatory cells such as PMNs and leukocytes, and because of this, the basement membrane permeability is decreased, leading to a decrease or reduced glomerular filtration surface area, which thereby would decrease the glomerular filtration rate. Because of the decreased GFR, there will be salt and water retention, leading to ECF volume expansion and edema or generalized circulatory congestion. Let us now look at the typical clinical course of acute glomerulonephritis. The latency period can last for 1 to several days. This is followed by the oliguric phase, diuretic phase, and early convalescent phase. Being familiar with the natural course of the disease will help the clinician intervene at the right time. The latency period varies from a few days to several weeks depending on the antecedent infection. 1 to 2 weeks for pharyngitis and 2 to 6 weeks for pyodermata. This is then followed by the acute nephritic signs and symptoms. This is followed by the oliguric phase, which would last for 7 to 10 days, which is characterized by signs and symptoms of salt and water retention and impaired kidney function. This is the phase wherein complications such as hypertensive encephalopathy, congestive heart failure, and acute renal failure may be found. In reality, the period between the latency period and oliguric phase is very significant. This is the critical time. It is during this period wherein careful and deliberate decisions may either lead to unnecessary morbidity or safe recovery of the patient. The diuretic phase would also last for 7 to 10 days. This follows wherein the patient's condition progressively improves and that the gross hematuria may start also to improve. The next 7 to 10 days is the convalescent phase characterized by improvement of the patient's well-being and resumption of pre-illness activities. There may be gross hematuria or significant microscopic hematuria during this phase. Let us now briefly look at the clinical manifestations of the disease. The most common of which is hematuria, which may be gross or microscopic, and the assumption is that hematuria is due to RBC hemolysis due to glomerular capillary wall leakage. The other common manifestation is edema. This may start periorbitally, noticeable upon waking up, and then gravitates to the lower extremity on prolonged standing or what we term as bipedal edema. Generally, edema is usually due to salt and water retention. Hypertension is another manifestation which is related to increased intravascular or ECF volume expansion or what we term as relative hypervolemia. Hormonal factors that does not play a role in the development of hypertension in these patients, and this should be suspected in the presence of cerebral symptoms. Cerebral symptoms may be in the form of headache, nausea, vomiting, sensorial changes, irritability, nuchal pain, or even transient visual loss. This is usually related to increase in blood pressure. Also, encephalopathy would usually depend on the severity of the hypertension. This is based on the absolute change of the patient's baseline blood pressure and the rate of which it has risen. This can also result from the direct toxic effects of the streptococcal antigens on the CNS. Another noticeable manifestation is oligoanuria, wherein the patient voids rarely or goes to the toilet frequently without passing urine. This is due to a decrease in the glomerular filtration rate. Signs of fluid retention or salt and water retention are usually manifested in the cardiopulmonary system. It may present as respiratory distress in the form of tachypnea, dyspnea, orthopnea, or chest pain. This is not related to increased blood pressure, but it is due to the increased extracellular fluid or due to the relative hypervolemia. Anemia may be seen in these patients, but these are usually transient and dilutional in nature. This is due to hemodilution as a consequence of the relative hypervolemia. Renal insufficiency or azotemia may also be seen in these patients, although the precise cause is not known, but it is probably due to the reduced glomerular filtration surface area or reduced capillary wall permeability or both, which resulted to a decrease in the GFR. So it can be seen that the diagnosis of AGN is not difficult as long as hematuria, edema, and hypertension are present. Laboratory findings that may support the diagnosis are as follows. First, on urinalysis, hematuria is the most consistent and it is defined as greater than or equal to 5 RBCs per high power field. RBC cast may be seen, which simply localizes the site of bleeding to the glomerulus in 60 to 85% of patients. Urinalysis may also reveal proteinuria, which is usually in direct proportion to the degree of hematuria. Leukocyturia and or pyuria may also be seen, but it does not necessarily suggest infection. As previously mentioned, anemia is delusional in nature. The renal function test may be normal to increase and there may be associated delusional hyponatremia. In severe cases wherein renal failure may be seen, electrolyte in the balance in the form of hyperkalemia, hypocalcemia, hyperphosphatemia, as well as metabolic acidosis may be seen. Serologic evidence of streptococcal infection may be documented by the anti-streptolysin O or ASO titer. This rises 10 to 14 days after pharyngitis and it may not be elevated in patients wherein the antecedent infection is pyoderma. Lipids or skin lipids usually binds the streptolysin O. That's why it may not be also elevated in patients with skin infection. And previous antibiotics may blunt the increase of ASO titer. The single most sensitive indicator of previous streptococcal infection is anti-DNase B titer. This is usually elevated in 90 to 95% of patients. One of the most important immunologic evidences of acute glomerulonephritis is serum C3. This is usually depressed in 90 to 100% of patients. However, serum C3 levels may be normal in 11% of patients based on foreign data, and local data would mention that 27% of cases may have normal serum C3 level. The degree of depression is not correlated with the severity, the sites of infection, nor the eventual outcome of the patient. Serum C3 usually normalizes within 6 to 8 weeks in 94% of patients. And if there is persistently low levels of serum C3, this is suggestive of chronic glomerulonephritis. Imaging studies for Patients with AGN would just signify the acuteness or the chronicity of the disease. Nephromegaly simply signifies an acute process, while small kidneys implies a chronic condition, wherein because of the contraction of the kidneys, the corticomedullary areas are not well delineated. The renal parenchyma are usually hyperechoic, wherein the corticomedullary areas are well delineated. Diagnosis of post-streptococcal acute glomerulonephritis is usually not difficult when the following are present: the history of previous streptococcal infection, nephritic signs and symptoms in the form of edema, hematuria, hypertension, serologic evidence of recent streptococcal infection, and a decreased or depressed serum complement C3 or C3 level. As previously mentioned, several complications may be seen during the oliguric phase of the disease. Hypertensive encephalopathy should be managed with diuretics and antihypertensives. Anticonvulsants may be given if the encephalopathy is very severe. Acute renal failure is managed by low salt and low protein diet, and if there is associated metabolic and electrolyte imbalance, correction should be done. Dialysis done if necessary. Congestive heart failure as a complication is usually managed with oxygen therapy and antihypertensive. Diuretics are usually given, preferably loop diuretics. However, the role of digitalis has no place in the management of acute glomerulonephritis unless the patient has a pre-existing cardiac disease. Let us now go to the management of patients with AGN. First in the management is the supportive phase of the treatment. Bed rest should be given. There's limitation of physical activity because of the hypertension. Salt restriction is recommended, as well as fluid limitation so as not to further the salt and water retention. Drug therapy in the form of diuretics such as furosemide may be given to promote sodium and water excretion. Antihypertensives such as calcium channel blockers in the form of nifedipine, amlodipine, as well as hydralazine may be given when indicated. The use of antibiotics is sometimes controversial. Penicillin and/or erythromycin may be given to eradicate residual streptococcal infection. One of the most important aspects in the management of patients is the monitoring, especially the daily weight of the patient. This would assess the effectiveness of the diuretics being given, as well as the fluid balance, which is between the intake and output of the patient. Daily or regular blood pressure measurement should also be emphasized. Let us now go to prognosis. In general, the prognosis of patients with acute glomerulonephritis is good and self-limiting. There is complete recovery in 90 to 95% of patients, and clinical recovery is usually expected within 1 month from the onset. Remember the 3 phases of the disease. 7 to 10. One of the most important aspects in the management of acute glomerulonephritis is the follow-up and monitoring the resolution of urinalysis and laboratory findings, particularly serum C3. Being familiar with the expected findings will guide clinicians avoid unnecessary treatment and reassure patients and caretakers to understand the natural course of the disease. Macroscopic or gross hematuria will usually last for 2 to 3 weeks. Microscopic hematuria, on the other hand, may last for as long as 6 to 12 months. Proteinuria will usually last or normalize within 3 to 6 months, and as mentioned, serum C3 level will normalize within 6 to 8 weeks. Histologic resolution, if renal biopsies are done, would be within 1 to 2 years. In summary, I have discussed with you the basic differences between nephrotic syndrome and glomerulonephritis, as well as the typical course and its correlation with the pathophysiology to the manifestations of glomerulonephritis, as well as the proper diagnostic modalities for these patients. Management in the form of supportive, therapeutic, monitoring, and resolution of urinary and serum C3 levels were also emphasized. Thank you for your utmost attention. Please answer the post test. All for the Filipino child.